Hello and welcome, and thank you so much for joining this first in a series of seminars which are being run by Asthma UK and the Primary Care Respiratory Society. My name is Monica Fletcher and I have the pleasure of chairing this meeting this evening. And you may be sitting at home on your own, but just to let you know that there are 450 people who are actually joined us tonight. And they've joined us from the 4 nations across the UK, and also we've got some international visitors. So thank you all very much. As you can understand, it's a very difficult evening to try and control the audience as such. So we're going to only take questions through the question and answer box at the bottom. So do ping your questions in during the evening. And if you want to upvote a question, you can do that. We're also going to be sharing the evening with our graphic illustrator, Claire, who's going to give you a little wave and say hello. And Claire is going to try and capture the evening by illustration. So at the end of the evening, we will have a summary of what's been said. So with no further ado, I think that's where we are. I'm going to hand you over to Catherine Hickman, who is the Primary Care Respiratory Society Right Care Lead, who will introduce you to Right Care. So thank you.
Thank you, Monica. Getting asthma care right is a huge challenge facing all of us in primary and secondary care. According to Asthma UK, 5.4 million people in the UK are currently receiving treatment for asthma, yet every 10 seconds, someone is having a potentially life-threatening asthma attack. And on average, 3 people die from asthma attack every day. Asthma Right Care was a social movement started by International Primary Care Respiratory Group among a group of European countries. It's a social movement, and it was born from a place of passion by clinicians who are passionately frustrated by the current state of asthma care. They started to challenge the status quo, be disruptive, rock the boat, and start to ask challenging questions of not only clinicians about their prescribing practices, but also of patients and how they are managing their asthma and their use of inhaled corticosteroids and also salbutamol inhalers. The Primary Care Respiratory Society is now co-badged with the International Primary Care Respiratory Group to work on Asthma Right Care, and we have a working group of clinicians who are looking to bust myths, challenge behaviours and make noise about living well with asthma. We have developed a number of tools and resources, all of which are featured on the PCRS website, and we're hoping to empower the profession to be leaders in responsible prescribing and allow patients to manage their asthma, not let it manage them. This is the first webinar in a series of webinars that we're running over the next 8 weeks, where we'll be discussing all things about asthma care and also bringing our tools and resources to life through video. We believe that you have joined today as you want to inspire change to improve asthma care. Asthma Right Care exists to support you to do this, and we hope that this webinar will inspire you to join our future webinars and get involved in the Asthma Right Care movement. Thank you.
Lovely, thank you, Catherine. Now we've got 8 speakers tonight, 8 panellists, and everyone's been given a really hard job. They have no more than 5 minutes, and what they're going to do from their perspective is to actually introduce the problem and maybe come up with the odd solution. And that's what the panel discussion is about. I'm sitting here tonight as a representative of the Centre, Asthma UK Centre for Applied Research, and therefore I'm delighted to introduce our first speaker, Dr. Erika Kennington, who is from the new forming charity Asthma UK and the British Lung Foundation. And you can see from this slide here that she holds great credentials to be able to introduce us and kick off the first talk of the night. So thank you, Erika.
Thank you, Monica. And I'd firstly like to thank Monica and the PCRS for your invitation to join you tonight. I'm really excited to be kicking this off, and especially on behalf of the third sector. And what I'm going to try and do in this first 5 minutes is give you a bit of an overview of the overall pathway to impact as we see it, and draw out some areas where I think this isn't working. And then I'm sure my fellow panelists will then go into more detail in some of these specific areas later this evening. So as you can see, I've titled my slide with something of a premise statement, and this underpins everything that my research, innovation and policy colleagues at Asthma UK, everything that we work for. So underneath this, you can then see a very simplified schema of how we get from research and innovation down to improved outcomes. So as we all know, research generates new knowledge. Innovation is then the taking of this knowledge to create something of value. So that product could be a new pharmaceutical treatment, it could be a new device, a technology, some software, or even a care pathway itself. Once we've got that product, we then generate a robust evidence base, and this proves things like safety and efficacy as well as cost effectiveness. The product then goes through regulatory approval, gets included into guidelines, rolled out to patients. The patient population uses that product, and that's what leads us to the improved outcome. But of course, we know the improved outcomes haven't been improving for a really long time. So this pathway is broken somewhere. Hannah, can I have one click on the slide, please? Thank you. And so I view this pathway as something of a leaky bucket. If you look at the guideline stage, we know that 60% of people aren't receiving basic care as described in the guidelines. And this is from our most recent annual asthma survey that Asthma UK carries out every year. And unfortunately, that figure is unchanged in our 2019 report that we launched 2 weeks ago. Additional to that, we know that up to 70% of people with asthma don't take their medication as prescribed. So that's a huge leak at the end of this pathway. And we know that people donate to charities for medical research because we all believe that if you put money into the top of this pathway and you pay for research, it will improve outcomes at the end of it. But if we've got a really leaky bucket like this, we can put loads of money in at the top and it's very unlikely to be improving those outcomes at the end. So what do I think we can do to the pathway as a whole? Hannah, one more click, please. So I'm going to suggest 3 things to start off with. We know a huge amount about the unmet need, and I think research in the last decade or 2 has really improved and focused on patient unmet needs. We've really engaged with the patient population. We understand where things are going wrong. I mean, we can look at these 2 stats on the screen, and we've subsequently done a huge amount of research. We now know why guidelines aren't being adopted or why then it's really hard to implement them. We know a huge amount why patients don't take their medication. We've done that research. I think there are people on this call who've literally written the book on that. But I think we're falling down at the innovation stage. And that's because we know that we've got an evidence base that these guidelines work and these existing products work. You know, we know from the National Review of Asthma Deaths that actually 2 in 3 asthma deaths are preventable if guidelines are followed and if existing medication is used. So we believe the product is right, but I think where we're innovating, we're trying to change the context. So instead of, we're trying to take a product that we believe works because we've got an evidence base for it, and thinking, well, it's the context that it's not working in. So we try and fix the broken health system, or we try and change patient behaviour. And I think what we need to do is actually accept that we have an overstretched and under-resourced health system, and we have a patient population with a whole array of different beliefs and motivations and behavioural phenotypes. And we need to innovate products that actually work in the context of those behaviours and those systems, rather than try and stick with the existing product and innovate new systems. So that's innovation, and sort of hand in hand with that is this robust evidence base. We're great at research. We generate really robust evidence. Unfortunately, I'm not sure we generate it in the right context. So I've just talked about we have to generate it in the context of the health system as it is. We can't do research only with respiratory interested researchers in respiratory focused settings. Similarly, we can't rely on using a population who are lucky enough to not have any comorbidities, because the evidence base will then only be relevant for that population. We know that the majority of people have comorbidities. So what we really need to do is, when we're getting this evidence base, we need to look at generating methodologies where we can have real world evidence. And when I talk about the population who's going to use this at the end, it's a hugely diverse population. And if we step back to the innovation stage, we need to be engaging that population and using user-centric design at all stages. It's not good enough just to kind of interview them at the start and try and work out what all their beliefs are and what will work for them. They have to be central to this product developments. Otherwise, it's very unlikely they're going to use it at the end. The final thing I want to touch on, because I know I'm probably short on time, is understanding this final section of the pathway. When we think of a pharmaceutical product, I think we understand this pathway really well. We understand who the payers are. We understand who's going to be making the product, how it's going to be distributed, how it's going to be prescribed, how patients are going to take it. But actually, when we consider a new care pathway or perhaps a new device, we've got very little understanding of what are the regulatory standards. They're changing all the time. How do we get something adopted into guidelines? Actually, if it gets into the guidelines, who is able to produce that product at scale? How is it going to be distributed? Are pharmacists going to be distributing devices now? We don't really understand this pathway and how it works. We've just assumed it will work in the same way as the pharmaceutical model, and I'm not sure that that's true. And until we understand that, it's going to be really, really difficult to carry this leaky bucket through a pathway we don't even understand. It's very unlikely we're going to get to the end. So those are three areas where I think we can really concentrate. And to try and end on a positive note, in all of those three things, the key solution to getting this is collaboration, and not just linking with friends and friends in the way that we've perhaps traditionally networked, but really seeking radical cognitive diversity, really making sure that we understand who are the players at each of these stages and including them at the much earlier stages, because only the combination of a robust evidence base and the incentive to scale is going to lead to a successful product. And I'm going to stop there. Thank you, Monica.
Lovely, thank you, Erika. Great start to the evening, and I think we've got the right speaker to follow you, because you've been talking about the healthcare system. No better to be able to talk a bit about that, but now to reflect on his own personal views is Professor Mike Morgan, who many of you will know as being a respiratory consultant from Leicester, but is also formerly the National Clinical Director for Respiratory Services in England. So over to you, Mike, for the second presentation.
Thank you, Monica, and good evening, everyone. You're quite right. This is going to be a personal and somewhat iconoclastic reflection. And I'm going to focus on asthma and mortality. And I think everyone is aware just how difficult it is to make meaningful comparisons between countries, as we've heard from COVID. And we also have a responsibility, I think, to examine our own data closely before we try and compare it with other countries and not just take it at first sight. So if you look first at the top left-hand panel, you'll see that these are asthma deaths in England and Wales from 2001 to 2018, and they're stratified by age. And every year we are told that there are about 1,200 asthma deaths per year. But if you look very closely, you'll see that 2/3 of those are over the age of 75. And the growth rate has been in the very elderly patients who have been coded as dying from asthma. I find this difficult to believe, that there's an epidemic of asthma in the over 90s that we have failed to recognize. If you look at the right-hand panel, you'll see that these are under 65 patients between 2001 and 2018. And they're more likely to have had asthma with that more accurate death certification. And you can see that actually we've done quite well. We have halved asthma deaths in the first decade of this millennium, but we haven't improved them since 2010. And probably it's only about 250 people a year that die from asthma. But tragically, when this happens, and it happens often in young people, as the clip on the left suggests, where chances to save lives are missed because there are preventable factors in deaths. And these preventable factors can be systemic factors, they can be patient factors, and they can be health professional factors. But this isn't new to us. This was most recently demonstrated in the National Review of Asthma Deaths, but there have been previous reviews which have said the same thing. But as a result of the National Review of Asthma Deaths, I was criticised quite heavily all the time by people saying nothing has been done, that there's been no policy changes. But that isn't true, because in England, there have been a substantial number of policy introductions. And I include the NICE guidelines to make asthma diagnosis more objective. There are QOF changes that are changed again this year to stimulate quality improvement. There's the respiratory program in the long-term plan. There are national and local commissioning incentives through Right Care and National Sequence. We have specialised commissioning now for people with severe asthma, and we have a national asthma audit. But these deaths are still occurring. And if you ask me what's missing, it's the notion that asthma is a chronic disease. Asthma patients are not unsuspectingly ambushed by asthma attacks, and that terminology persuades people not to think of it as a chronic disease. And there is no integrated care structure within our system in the same way that there is with diabetes or increasingly with COPD, to take a population view of asthma and provide oversight. We have specialists in hospital for asthma, but we have most of the patients in community care. So the thing that we've missed in all this, I think, is the integrated care structure to provide a population approach to asthma patients to ensure that they get proper oversight. So thank you, Monica. That's all I have to say this evening.
Fantastic. Thank you very much indeed, Mike. And that was really interesting because it takes us straight on to really Catherine, thinking about integrated care. Catherine, if you were here at the beginning and introduced the Right Care programme, and you can tell by the way she spoke that she's absolutely passionate about improving the care of people living with asthma. She's a GP who works in Leeds, and she's also Vice Chair of the Primary Care Respiratory Society. So here we are, integrated care. Catherine, over to you from a primary care perspective.
Thank you, Monica. So working in primary care can be tough. There's unprecedented levels of burnout, stress. We have a depleted workforce and multiple time constraints, as well as multiple different guidelines and hundreds of inhalers. And for many years, respiratory has not been prioritised either locally or nationally up until now. Yes, we have data from the National Review of Asthma Deaths and national audits, but unfortunately, little has changed. And I've started to feel like a stuck record. I've started to feel that I'm saying the same things over and over again, and I'm not seeing change happen. And I believe that many of us have developed bad habits. We're not making accurate diagnoses of asthma patients. We're not discussing what's going on in patients' airways so that they leave the room with a clear understanding of bronchoconstriction and inflammation. We're not tackling smoking properly. We're not making sure that patients know which inhalers to take and when. We're not discussing compliance or co-creating personal asthma action plans so that patients know how to manage their asthma at home and also what to do in an emergency. Bad habits have become ingrained. And when we step back and we think and we recognise that we know what we should be doing, but we don't always know how to change. Now, BJ Fogg is a behaviour change scientist at Stanford University and somebody that I trained under in behavioural change. And he talks about the ability chain, which is the bottom left of the slide. And if we think about it, asthma care can be broken down into components, individual clinician behaviours. And for each behaviour, we need to ask ourselves, do I have enough time to do it? Do I have enough money? Am I physically capable? Do I have the mental energy? And does this behaviour fit into my current routine, or does it require me to make adjustments? Our ability chain is only as strong as its weakest ability factor link. Take personal asthma action plan, for example. I can have the money, the physical and mental capability of doing them and making it routine. But if I haven't got the time, I won't write a personal asthma action plan for the patient. If all my links are in place, but the money one is broken and the practice manager won't buy a new spirometry machine, then the patients will continue to get inaccurate diagnosis. I may be physically capable of demonstrating inhaler technique to patients, but if I don't have placebos, then I won't do it. Equally, I might have airway models on my desk, but I don't feel confident about discussing the pathophysiology of asthma with patients. And if compliance isn't embedded in your routine template, then it's unlikely it's going to get discussed at an asthma review. It's not as simple as just giving nurses more time to do a review, because if they haven't been trained to fill out a personal asthma action plan, it won't happen. Equally, a GP can have the physical capability to demonstrate inhaler technique and as many placebos as possible on their desk, but if they only have a 10-minute consultation and they've already covered 2 problems, it simply won't happen. We need to stop and think and pause. And for each behavioural component of asthma care, we need to ask ourselves, what is making the behaviour hard to do, i.e. which part of my ability chain is broken, and how can I make the behaviour easier to do? And there are 3 approaches to making your behaviour easier to do. The first one is to increase your skills. So you watch videos, you attend webinars like this, and many months in the future, you go to face-to-face learning. You learn how to talk to a patient about how to use a peak flow diary, how to create a personal asthma action plan, and learn how to talk to patients about the pathology of asthma so they have true understanding of the nature of their asthma. You also understand how to talk to patients on compliance of the inhaled corticosteroids and also over-reliance on the salbutamol inhalers. And if after that you feel educated on each of these particular behaviours, you then need to consider, do I need tools and resources? How can I change my environment so that I make it easier to do the right thing? I have placebos readily available. I have a personal asthma action plans either printed out or embedded in my clinical system. The asthma slide rule is on my desk, ready to be used with patients or available on my desktop. Airway models, easily accessible and on my desk so I can talk about them with patients. I have quick access to inhaler videos and the ability to text the link to patients there and then. And if after you have had education, you've got all the tools and resources in place and you still haven't changed, you need to give yourself permission to go small, go tiny. After I prescribe an inhaler, I will get out a placebo inhaler. After I prescribe a salbutamol inhaler, I will automatically check the inhaled corticosteroid compliance. After a patient walks in for their asthma review, I will open up their personal asthma action plan. Plant a seed in the right spot and it will grow organically without further coaxing. You need to celebrate your successes, feel good. Emotions create habits. Feel good about the progress that you're making, and over time, the good habits will replace the bad habits and become ingrained, and asthma care, I hope, will start to improve. Thank you.
Lovely. Thank you very much indeed, Catherine. Lots of food for thought there. Go small, but think big, I think. We're now going to pass over to our next speaker. And as you will see from our range of speakers, we've tried to capture the diversity of clinicians and others involved in asthma care. So here we have Darush Attar, who is going to present on behalf of the pharmacy. From my years of working in primary care, the pharmacist, when I was a child, the pharmacist was one of the most important people that everybody went to. And then for many years, it became a very different profession. I think we've seen in recent months how important the pharmacy is as part of the whole chain. So I'm delighted to introduce you to speak now from the perspective of an enthusiast and another member of the Primary Care Respiratory Society about the role of the pharmacist and your views. So thank you, Darush.
Thank you, Monica. So I'm delighted to be here, and I'm so proud of my pharmacy colleagues, especially those in community pharmacy who are on the front line and supporting so many people during the pandemic. So one of the things that I'm hoping we're seeing now is that in primary care, we really need to tap into the expertise of the pharmacist and the pharmacy staff. So you've got the pharmacy technicians and the pre-reg pharmacist and the counter assistants. And just to know that you're never more than 20 minutes away from a community pharmacy with, 5 years of training the pharmacist has gone through and got a lot of expertise, real medicines experts. And I know that when it comes to asthma basic care, when Asthma UK talks about inhaler technique, a personal asthma action plan and an annual asthma review, basic care, it's very hard to cover all of these things in a GP practice, and we really should be looking at the skill mix. So the new medicine service, so if a person gets a new inhaler, they need to know about how to use that device, of course, but they also need to know as well what's inside the device and what that medication is for. If they know what it's for, then of course they'll be empowered and more likely to take it. For example, we'd want people to take their preventer treatment. And there's pharmacy, the payment, there's the quality scheme as well that's available now, where people can For example, these are high-risk situations. If we've identified patients who are getting the blue inhaler over and over again, and this is where you'll see that in the pharmacy, because sometimes people order repeat prescriptions and order it over and over again. And it means that we can be alerted that that person is at risk and they're not taking their anti-inflammatory medication that they need. So pharmacies are considered as healthy living pharmacies now. They're well-being centres. You can get to speak to somebody without having to make an appointment, and that's really important. Smoking cessation has been an offering that we've been able to do for many, many years, and we can do that from the very brief advice, the ask, advise and act, from as little as 30 seconds. But I still think that whenever that blue inhaler arrives for asthma, and remember for COPD it can be used liberally, but for asthma the warning signs should be there, knowing that each time we advise a patient that that one canister with 200 puffs in there should really last 6 months. So lots of education and support is needed, and we do a lot of signposting to people who are at risk. So the asthma risks acronym I use, for example, is because if you have a patient medication record, you could identify the ratio of ICS and SABA. And if the person's getting, for example, 2 ICS over a 12-month period and 6 SABA, for example, you know that this person needs some education and support and potentially at risk. The I is for ICS, so looking at the ICS strength and also the adherence. The S is for smoking cessation. The K is for knowledge. And of course, the National Review of Asthma Deaths identified, for example, 73% of patients were without an asthma plan. I think good news is recently from the Asthma UK survey, it's looking like it's improving to around 50%, but there's so much more we can do to educate patients about the importance of having an asthma plan and signposting to the practices. In Northwest London, for example, we've got some of the patients and the pharmacies to actually fill out the green section and then fill out the rest of the plan in the GP practice. As part of the green agenda, just thinking that if you've got somebody who comes in for the first time, you know, coming into the pharmacy, they put in giving their prescription, that conversation around the blue inhaler is very, very important. But then when the person is getting also, you know, they're coming to get, for example, recycle their inhaler, they'll need to go to the pharmacy again. And that's another time where we can catch a person and inform them about the importance of good asthma control, for example, and how that can be done. So what's been a privilege is working with Primary Care Respiratory Society and the International Primary Care Respiratory Group around, and knowing that the community pharmacy colleagues are not forgotten in this whole social movement. We really need to highlight that and correct any misunderstanding, for example, that the blue inhaler is not there to open up the airways prior to using ICS. That's old advice, and it's not something that we should be sharing. So we can really use the pharmacies to help patients understand the importance that ICS regular use is important. The asthma control test is available. We can see that person's control at that moment in time, and I'm finding that in the community pharmacy, again, we can get our colleagues to ask patients to fill that out. There's reliance, getting into the ideas, concerns, expectation of the patient, the reliever reliance test, understanding people's beliefs about their medication. What does good asthma look like? So many things we can do to improve asthma management and of course prevent people from doing risky behaviours. So hopefully that just gives you a top line of what pharmacy can do in the community, but of course there are also lots of pharmacies working in GP practice as well. And I think that whole multidisciplinary team working is really important. Thank you.
Lovely, thank you so much. I'll remember that one. Only 20 minutes away from the pharmacy, wherever you live. That's fantastic. My speakers are really great the way they're bridging between each other, because Darusha's just alluded to patients' beliefs and understanding. So if we move over to our next speaker, I'm delighted to introduce now Dr. Alistair Duff, who is an honorary clinical associate professor in Leeds. When we first started the Asthma UK Centre for Applied Research, originally we're going to run an event, and this is how we've come together with the PCRS. We were moving over to Leeds to run that. So Alistair was going to be our local speaker. Now, I don't know what's local when we're on a call like this, but I welcome you, Alistair. You haven't had to travel today, and here you are. So we're going to get the psychologist's viewpoint now.
Thanks very much, Monica, and thanks very much everybody for dialing into the call. I feel very privileged to be able to share my thoughts with you. Could I see the slide? Thank you very much. You'll see that I don't look like that photo anymore. That's because people never really took me very seriously without the obligatory bushy psychology grey beard. So hopefully you'll take some of this stuff pretty seriously, because I've been sitting in asthma clinics now for a good 2 or 3 years, and I'm just struck by how often the problems are behavioural, as has been mentioned by previous speakers, as opposed to medical. The simple fact is that drugs don't work in people who don't take them. And although that may seem trite, it's sometimes the very simple things that we lose the focus of, that we need to focus on in terms of helping people achieve good asthma control. So I often talk about what is the difference between optimal adherence and suboptimal adherence rather than poor adherence or non-adherence. It's very rare that somebody doesn't take absolutely anything, and it's equally rare that they take it all 100%. So we're looking at the margins that we would consider clinically optimal and clinically suboptimal, and I think that gives us scope for working with people in different ways. So optimal adherence will depend on optimal control. How do we improve optimal control? It's trying to get people to sort of adopt good self-care behaviours. Self-care behaviours, including a range of things that people have to do when they've got any chronic condition. That is learning how and when to take the medicines, as well as what to take. In asthma, I think we have got a problem with device techniques. I believe that there is probably 100 different products out there in terms of devices, all with different instructions. So even the simplest take 2 puffs twice a day recommendation in clinic can actually be very, very complicated. People will forget how to take it. They'll forget when to take it. They'll forget, is it that they breathe in slow and long? Do they tilt their head back, or do they tilt it forward? And they get out the information for patient leaflet out of the packet, and they plod their way through that if they're motivated. But if they're not motivated, then they give up. The other thing that I think I am very strong to talk about with young people is the amount of exercise they're getting. I think that there's a perception, and maybe I'm a bit out of date, or we've got a skewed population in Leeds that considers asthma as being an anathema to exercise. And so what's important is that we encourage kids to exercise in a way that builds their confidence to do so. And that involves working with the school system and with parents, as well as potentially sort of physios that we've got in our own clinics. At the last part, I think that's particularly important to asthma care and achieving optimal control is helping people minimize their exposure to known triggers. We know about smoke, we know about stress in some ways. We know less about how people continue to expose themselves to allergies, to pets, to other things. And again, when you add up all the self-care behaviours that we're asking people to do in terms of living their life despite a chronic illness, asthma is not a simple regimen for people to adapt to accept in their lives, and therefore adhere to optimally. So what are the factors that I would look at when considering a young person that is not adhering optimally, that's adhering suboptimally? And it is a conflation of factors that are both individual, systemic, and relating to the treatment. Individual will depend on the age and stage and the beliefs, the health beliefs that they have about asthma, about its treatments. And I often use Rob Horn and John Wyman's framework of necessities and concerns, where if you have very many more concerns than you have necessity beliefs, you're very unlikely to take your medicines. And it's a very simple model, but one that's quite effective when you are in a translational situation in clinic, trying to explain theory and understanding to people who you're trying to help. So age, stage and beliefs is where I would always start. What is the age of the child? What developmental sort of intersections does asthma sort of play in their lives? Does it make them feel more visible at school? Does it make them feel more different at school? And what beliefs do they have, right or wrong, about inhaled corticosteroids or allergies or wheeze or inflammation? These are all words that we use without batting an eyelid, but to even a bright 13, 14-year-old who may not be totally engaged in their illness, it's important to go back over some of these basics. It's important to consider the sort of systemic environments that they are working in, and I mostly consider their family, what support, what ability does a family have to communicate about adherence. What happens in school? Again, I think that kids just need to produce the asthma and they don't engage in certain activities. What about the peer groups? Is there any support? We talk about peer groups often negatively, but peers for teenagers and young adults are perhaps the most important source of support. And then we've got the treatment itself. Treatments that have got little immediate benefit, that take time and are believed to be intrusive, are very unlikely to be taken in any optimal way. I believe that sort of inhaled corticosteroids fit that bill. And so for me in clinic, I think we need to screen for people that might be at risk of poorer adherence than others. And we need to tackle the AAAs, as I sort of call them, in a clinic setting: adherence, anxiety about asthma, and allergens. And I'm being waved at by Monica now, so I'm going to stop and pass on to the next speaker. Thanks very much for listening.
Thank you, Alistair. I'm sorry, because I could have listened to you for ages. And fantastic talk. Thank you very much indeed. And so often we just go 2 puffs, and there's so much more behind that. My next speaker is Dr. Dave Leather, who is currently the Medical Vice President for GSK Respiratory Therapy Area at the global level. Dave is also a past GP and is very proud of being a past GP. I've known Dave for many years, and I think he's going to give us his personal reflection from a broad perspective. So thank you very much indeed, Dave, for joining us.
Not at all. Thanks, Monica, and thanks for the invitation to speak this evening. It really is a privilege and a pleasure. I'm going to talk to you about the way I've sort of chunked things up, and I'm going to throw some things out there for you to think about, really. I might not be able to cover them in any depth, but I've chunked it up into peoples and attitudes, process and guidance, and then a bundle of what I've called other crucial stuff. The stuff in the top half of my chart is what I think would be considered an industry view, and I have checked with other colleagues in the industry just to check that through. At the bottom, they're definitely my personal views. Let's start with people and attitudes. Now, I'm going to start off with something that's pretty difficult, actually. So we did some market research in GSK in 2019, and we looked at the adoption curve model. And what you might be interested to know is that the UK has the highest number of healthcare professionals who are in the skeptic group. The skeptic group are the most difficult to engage with and change. Look at Japan, it's 20%. In fact, Spain's even lower at 12%. So this says something about the state of our healthcare professionals and the willingness to take on new things. And that might allude to some of the things that previous speakers have said, like Catherine saying, we've got bad habits that we need to change. The second thing I think is the industry and healthcare professional relationships. This varies a lot around the world. And I don't really think we've got this right yet. It works brilliantly sometimes, and sometimes it just is muddied, not clear, but worth thinking about, and I'll come back to that. Industry reputation in the UK, as you'll know, has not been great, and there are some things that have happened, I think, that have meant industry deserves some of that. But to some extent, you know, the industry, I think, does deserve to be a collaborator. We've all got the same aim in mind, making patients better. We just want another one to think about. My personal view on this at the bottom, I often wonder if we really are patient-centric. You know, I sometimes wonder if we go a bit guideline-centric, or, as people have already said, drug-centric and in our guidelines approach. I believe there's been a lack of disruption in the asthma space. I'll come back and touch on this. I think we need disruption to make change happen, particularly around the simplification of our approaches to treatment. I think, as well, as being a lack of focus on implementation of guidelines. We work really hard at the guidelines, but do we really look at if they work and what difference do they make? Really key area. And this one might be a bit tough, and I'm from the UK as well, but I sometimes believe that the UK believes it's the epicenter of respiratory medicine, and it's at the center of the respiratory world. And we should ask ourselves, are we? And can we learn from other countries in the world, like Japan, that have actually had a more rapid improvement in asthma care after a very slow start? Process and guidelines. I'm going to kick off with step up and step down guidelines. This made no sense to me when I was a GP. I can't think of another disease where you manage risk, where you step down after you reduce the risk. I don't know what this does to GPs or patients, but I think it's confusing. Second big bucket is regulatory frameworks. It probably would amaze you that there is no regulatory framework, for example, on the colour coding of inhalers or on the nomenclature. That's a gap, and it's a difficulty for the industry. The other thing that's puzzled me about evidence-based guidelines is, if they're evidence-based, how come they're different all around the world? And they are. And then finally, you know, regulators are in a very difficult position. They have to really take on the responsibility of licensing medicine on behalf of all of us. And actually, they have dossiers and frameworks that deliver that, but it actually can stifle innovation because industry creates evidence within that framework. Down here are my personal views on this one. I think we failed to embrace and drive new concepts. I think cardiovascular risk did this. On the basis of epidemiological evidence, they drove massive changes and simplified what is a multifactorial approach to risk management with great success. Something for us to think about. Something I feel very strongly about is I think there's too much emphasis on the internal and scientific validity of studies and little focus on external validity. Erika touched on this right at the start. I'm a big believer in effectiveness research. Interestingly, generally, effectiveness research is not accepted by regulators. Other crucial stuff and things I think I've observed in my time in the industry, you know, very often our academic centres and patient groups are sometimes in competition, when if we could work together, we might get further. I think there's another problem that R&D and the commercial parts of pharmaceutical companies are not seen as one. People sort of separate them out, though one's good and one's bad. We've got to do something about this so that we work together and find mutually acceptable ways of working. At the end of the day, industry makes the tools that allow healthcare professionals to do their jobs. It's what we do, it's what we do well, and we do it incredibly reliably. Finally, pragmatism and leadership. You know, if you've been to Finland to see the incredible success they have there, I expected to see incredibly well-organised asthma clinics churning through protocols. Actually, when I went there, I felt that change happened because of pragmatic leadership from one very charismatic person who had a very clear message. Simplification, to me, is one of the ways that we can take those skeptics with us in our ambition of improving asthma. Collaboration is not a one-way street. You know, we have to work at that. And by that, I don't just mean industry and healthcare professionals. It means all of us together collaborating, finding common goals. I mean, how can we have different guidelines around the world? And then finally, I think to touch on what Mike pointed out, he said, you know, we've really done quite well. And I think that's part of our problem. We have done very well. And this quote from Andy Grove sort of sums that up for me. You know, success breeds complacency. And complacency can breed failure, and only the paranoid survive. So for me, really, under these three headings, it's really about disruption, simplification, and being a bit paranoid and not being complacent.
Thank you, Dave, and thank you for disrupting us. I'm sure we've got lots of things to pick up from your talk, but I need to move on to our next speaker. And I'm delighted now to introduce Dr. Linda Edwards. Many of you know that I was privileged to head up this organisation, Education for Health, for many years, and handed over the baton yet again to Linda, who's doing a fantastic job. So Linda's going to bring a perspective now from her role as Chief Executive of Education for Health about the role of education and knowledge. Thanks, Linda.
Thank you. Thanks, Monica, and thank you, everybody. I think when I arrived at Education for Health a couple of years ago, the question that was kind of burning in my mind was how can we use education to demonstrate improvements in health? I come from a background of a great passion about how can we improve health outcomes for people and a passion for primary care. So bringing those two together at Education Health seemed like a gift from heaven for me. So arriving there and looking at how, if I was a healthcare professional, why would I want to invest in my education? Based on the experience I had at both Asthma UK and Diabetes UK, I was very aware that actually having a simple tool that people could use in primary care that would help them to target their population for a particular disease area was fundamentally important. At Diabetes UK, we created a profiling tool that enabled us to demonstrate the changes that could happen. For instance, across one CCG area, 800 people who hadn't had a diabetes check before had a diabetes check following the work that we did there. Likewise, 534 people achieved their HbA1c, and 300 people in that particular population was deemed as achieving good control against the 3 NICE targets. So the question for me was, how can we translate this into respiratory disease and particularly into asthma? So you'll be pleased to know that we have finally developed our profiling tools in asthma and COPD, and we are being able to implement those now, which the timing of it is absolutely amazing, because clearly with COVID, it's going to be more and more important that people are supported in managing their patients with respiratory conditions. So, for example, some of the measures that we can easily do are around the asthma review, how many people are having their reviews, how many people are using asthma action plans, how many people are having an assessment of their level of control around ACT, ACQ, or the RCP, and adherence, which several other speakers have talked about today. So that is now contained within a profiling tool. People can then attend a asthma level 5 or level 6, so that's diploma or BSc level short course, be given the skills and the knowledge to enable them to implement that in practice. But the key that was missing for me all along was coaching people into practice. Education alone is knowledge without know-how. So you can know your population, you can go through the training program, but then what happens? You're left alone quite often in a practice without another person who understands your area of expertise or the training that you've just been on. And you need some support in actually implementing that into practice. As many of the other speakers have been saying this evening, everybody's different. How do you get people to change their behaviour? How do you get people to be more compliant in their medication regimes? How do you help people to change their lifestyles? And how do you work against, or along with, should I say, the beliefs that people hold? And working with a behavioural psychologist or someone who's trained in coaching can actually help you implement those changes within those individual patients that people are seeing day in, day out. And so the process that we use is following on from someone attending one of the training programs, which are all moving online, you'll be pleased to know, at the moment, based on what's happened with COVID. Then 3 to 6 months later, you can remeasure your population and understand the benefits or otherwise that the education has had on how you manage your patient. Key to me is keeping this really, really simple. There are lots of amazingly good complex profiling tools or dashboards out there, But for me, the key to all of this is keeping it simple so that people can manage on a day-to-day basis and understand how they can support specific groups of their patients. That's what I wanted to say.
Lovely, thank you, Linda. And again, I think the importance, as we had the talk about guidelines, is actually, it's all very well learning or knowing the guidelines, but how do you actually implement that into practice? And I'm sure we'll have some questioning about that. So we're on to our final speaker, and then you will all get a chance to have your questions. But I'm delighted to have our final speaker is Professor Hilary Pinnock, again, somebody I've known for many years, who is now in Edinburgh and has been involved with the Primary Care Respiratory Society, is involved with the ERS now as Chair of Assembly 1, Asthma UK Centre for Applied Research. And what Hilary will now bring is actually a research perspective to pull perhaps some of our other talks together. So thank you very much indeed, Hilary. Last but certainly not least.
Thanks, Monica. Yes, I'm very much going to pull from some of the thoughts that have already come from other speakers, and I think you'll recognise I'll try to remember to allude to some of the themes. I've decided to take the theme of research into practice because I think that's what I was asked to do as to why we're failing at times to deliver better asthma care, and it's around why do we not implement research into routine practice. Researchers listening to this will recognise at the middle at the top of the of my slide, the MRC framework for developing complex interventions, though a similar framework will apply to any intervention that you were developing. You have to develop the intervention, theoretical viewpoint, you have to test its feasibility, its acceptability, then you might go on and do a randomized controlled trial to prove whether it's an effective intervention. And if it is, you then disseminate it, and you naively think that by some sort of magic, every practice in the country, every clinician in the country will take it on and implement it. But quite clearly, as my red arrow shows, it just doesn't quite work like that. There's many reasons for this, and I'm going to try and touch on a few of them. One of them, and this has already been hinted by some people, I think, Dave Leather, you touched on this, guidelines look at RCT evidence. They take these randomized controlled trial evidence, but of course that isn't the world that we live in. Randomized controlled trials typically take perfect patients, pure patients with no comorbidities. They would exclude the elderly, they would exclude the pregnant, they would exclude people who are non-adherent. No, I'm sorry, that's not suboptimal adherence, I believe is the better term, but they exclude people who can't use inhalers. They exclude so many patients that in fact many of the studies that we base our evidence on actually have only taken in something like 5 to 10% of the patients that we see in general practice. So we've got evidence in guidelines, objective evidence produced into guidelines, which actually comes from a small percentage of the population in randomized controlled trials, delivered in ideal circumstances where there's enough resources there to deliver the intervention, trained staff, delivering the intervention with high fidelity, not the real world we live in. So there are limitations to that. And what we need, I would suggest, is another cycle of thinking about how we implement these guidelines. This, of course, is implementation research. And this actually involves a process, again, of developing, not this time the intervention, but an implementation strategy, how we are going to implement that intervention. That goes through a process of feasibility testing, checking acceptability, piloting, before we evaluate that implementation in order to produce a sustainable, implementable intervention. So I would suggest that one of the reasons that we're not actually delivering implementation is partly because we're not focusing enough on implementation research and the messages that it teaches us about how we have to think about what the patients need, the resources that they need, the information that they need. We need to hear what the professionals need, and I heard Linda talking about the skills that professionals required, but we also need to think about the organisation and how this is actually delivered in a practical way. I want to just touch on context, because anybody working in implementation research will instantly say context is everything. And I'm going to give you a somewhat dramatic example of context, which is currently amusing me. Some 15 years ago, I published a paper that showed that if you provide a telephone option for people in reviewing their asthma, their control was no different to if you reviewed them face to face, but more people got a review. It improved access to healthcare. Now, this all happened at the time that QoF was being introduced, and people looked at this suggestion and it was regarded as cheating, and a number of authorities actually banned, and trusts banned their practices from providing telephone reviews for asthma. A month or so ago, coronavirus hit. We all converted everything we did to telephone, to video links. We started to discover these remote methods of consultation. Bans were lifted, and I will predict that over the next few years, we will start doing telephone reviews for asthma, video reviews for asthma, in a way that we couldn't have believed. Context has changed. Research governance doesn't help us. It's designed for drug trials or focused RCTs. It is not designed for implementation research. And I constantly, that picture at the bottom is clearly me getting tied up in red tape, filling in forms with questions that don't mean anything to the sort of work I'm doing, where I'm trying to encourage practices and evaluate an implementation strategy. So research governance works against us, but guidelines, which are to some extent a bit of a problem, can also help. The BTS sign guidelines for asthma explicitly looked at the how-to question. Most guidelines stop at you must deliver supported self-management, full stop. They don't actually go on to say how that can be done in practice. One of the things that we did in the BTS sign guideline was to have a short section on how do you actually implement this in practice. That means looking for a very different sort of evidence for research evidence. So a few thoughts around how you put research into practice, and it comes to investing time, money and resources, and thinking into implementation research and taking that as a science in its own right, and not just stopping at the randomized trial and hoping that somehow it will get into practice by some form of osmosis. Thank you.
Lovely, thank you, Hilary, and thank you for pulling all the presentations together so nicely. So now what we're going to do is open up to the panel. And I think I will ask all of my panel to put themselves onto their video link. So if you will open up wherever you are, that's fantastic. So you'll see, as everybody is getting ready, it's really interesting. I don't know how many of you are watching all these Zooms on the television at the moment, but you do know those of you that sit in front of a bookcase are meant to be the most learned of all of us. So I see have some bookcases behind you, my professors. There's a few who have not exposed their pictures yet. So David, Darush, please. Linda's here still. I do understand that Linda has to go early, so I think we probably need to move a little bit more into a question that would be relevant for Linda, and then we will let you go, Linda, when you need to. And I think a theme that we've had coming through here is about real life evidence, real life. We've had real life we were challenged right from the beginning about trials. I know that David is a great proponent of real world evidence, and what Hilary was saying at the end there. So how do we actually, the question that's sort of coming out is, you know, our clinical trials are not real people, what we deal with is not real. How do we actually sort of bring this more alive? And I just want to capture Linda's thoughts, which was, education itself is nothing unless people implement it. So have you got a wise word, Linda, to add to your talk about implementation of knowledge, and then we'll move on to the science? So Linda, what are the key things? You've talked about coaching. Anything else you could think about or share with our listeners about implementing this into practice?
I think one of the biggest problems that we have is people listening. And there are different types of listening, and a lot of the time we apply pretend listening, but actually if we really take the time to listen, people will tell us what they need, and therefore we can help find solutions to those needs. That would be the one thing that I would always tell people. any good coach, any good psychologist will know how to really listen.
Wow, Alistair's right next to you on my screen. What would Alistair say to that? Need to demute. Mute, Alistair.
Sorry, I had my video on, but not my microphone. Can you just repeat the question for me, Monica?
I was talking about implementation and the issues about implementation, and Linda just passed the baton on very nicely to you and talks about the psychology of implementation, whether that's education, whether that's patient education, whether that's health professional education, the implementation.
Yeah, I mean, I think I was also just sort of looking at some of the questions that were coming up on the chat and the Q&A that are asking similar sort of questions about how do we bring this together in a kind of novel way, in a way that takes us forward, and there is no one answer. I think that the education before medication has got to be part of it. If people don't understand or believe that what they need to do is important, then they're not going to take it. If they then don't understand how to take it at home without a big A4 0.4 font size patient information sheet, they're not going to read it, they're not going to take it. If they don't feel that we're listening to them in clinic, they're not going to attend, or they're not going to tell us the truth. And so the simple way forward is to engage with patients, is to listen to them, to provide them with education in a way that they can remember what we're telling them. So it has to be much more interactive. And then really just talk to them about why it's difficult for them. So it's a blend of those three things that have to be baked like a cake in front of the patient in your 15-minute, if you're lucky enough, consultation, 5 minutes if you're in primary care. But you can achieve a lot by listening in 5 minutes, far more sometimes than you can for talking for 5 minutes.
Mm. And bringing in others on this, and I look to Dave here about you mentioned guidelines, and do we not do the same thing with healthcare professionals in a sense? The guideline arrives on the desk and we're expected to follow a guideline. In a way, that kind of thing is passing down the food chain to sometimes our behaviours with patients. We know what to do, we tell them what to do. What could we do better with implementation of guidelines?
I think guidelines are really interesting, aren't they? Because Hilary said it all for me. They're based on, predominantly double-blind randomized controlled trials that don't represent 95% of the patients we treat. There's a fundamental massive flaw in evidence-based guidelines. And, to me, it is all about let's drive forwards the cause of effectiveness research and implementation research. And that's a tough one. I mean, I think it's sort of a long way around your question, but I think we have to produce that evidence research, look at the implementation research and recommend what's best and most simple for that person in front of you. That is a radical change from where we are now. I commend BTS Sign because they are one of the groups that have really looked at this. Not true everywhere. I mean, in fact, Gina's hardly looked at it. So, and that takes all of us to do that, because industry needs to start producing that research. So the researchers out there, to make it happen, regulators need to accept that research as being valid, then industry will start sitting behind it. If guideline writers include it, industry will do more of it, and researchers will get the opportunity to do more. So there's quite a complex web of things. I thought Hilary's session was fantastic because it pulled it together for me, because it connected the sort of patient with the research piece. And then I think what Alistair's saying is, then we can look at research-based simplified guidelines and look at implementation and do what works instead of what we think works in that 5% of people in ideal circumstances. So quite a complicated web. I don't think it's impossible to change.
And Erika, you started off this whole discussion really right from the very beginning, and I'm just wondering about bringing in, making things realistic. Somebody referred to we're often looking for this pot of gold at the end. One of the questions came up about real world evidence, and so co-creating some of this with patients and getting patients involved in guidelines and everything, research as well. What's your view? Will that make things better? Erika, you're on mute. Erika. Oh, Erika's frozen. So Hilary, I'll go back to you really, and thinking about, because you started us into this sort of discussion there. So yeah. Oh, you're on mute too.
Not for long. Yeah, there's lots I could say really there. I really do think that we need to put more emphasis on implementation research. Nothing stops at the point of an RCT. And that's for guidelines, it's for governance that causes us endless problems at the moment. Can I just put out a completely horrifying thought, Monica?
Yeah,
we need to start realizing that healthcare professionals are people. And like any other person, we need to be, our behavior change is complex. And all the things that I've been hearing about, encouraging patients to take their inhalers, we need to encourage clinicians to change their practice. And we change our practice with the same reluctance and difficulty, but also for the same reasons that patients change their behavior. Or don't change their behavior. And one of the things I've learned is that the crucial people in any team that I'm working with are the health psychologists who understand behavior change and can actually help build in behavior change for the clinicians, for the managers in our practices, as well as, of course, for the interventions that we are providing to the patients. So if there is a message, I think it's just that we're human and our behaviors don't change that easily either.
No, absolutely. And I suspect Catherine would echo that from a GP who may be having guidelines thrown at you from every direction and being told you're not doing this, you're not doing that. What's your thought on what Hilary just said?
Yeah, I fully agree. And I think, and we have to recognise that we are all human beings and we're absolutely rubbish at changing. And if we continue to do the same things over and over again, we're going to get the same outcomes. I think in many ways, I actually think it will be harder to change the behaviour change of clinicians than it will be of patients. And going back to something that we talked about, really listening to patients, I think there's something about really listening to what matters to them, because we've got our own agenda, haven't we? You know, we want them to take their steroids and we want them to stop using the salbutamol, but what's important to them, and what do they want back in their life that they haven't got, that they've sort of just accepted that they're using their salbutamol inhaler 8 times a day because that's the norm, but actually they've stopped running, they've stopped walking, they've stopped playing with their grandkids, and actually could that be a spark to make them change, rather than, you know, relying on us dictating to them why they need to change.
Right, and I think that's fantastic, because a question that's come up, and maybe the terminology will make you all feel a bit uncomfortable, and I push this one over to Darush, is the question that's come out is, how do we stop the Ventolin addiction? Now, the terminology of that question is sort of not embracing where the patient is actually coming from here. I just wonder, I don't want all the solutions about, you know, everything, but how about that as a question?
It's a good question, and it is. This is why we talk about over-reliance rather than overuse, because it has become, why would you want to take the inhaler that person really likes, and it's the one that is embedded in their brain cells as this is the good one. So it's there's a lot of education, of course, needed, and I think, just like when I talk to smokers, it's important how we can, you know, go smoke free, use positive languages rather than giving up. When I'm talking about, you know, living with asthma rather than suffering with asthma, it's trying to help a person live with good control. And one of the good indicators there is not to give something that's not going to help the underlying inflammation. So I think if we can work in a partnership here and always have a glass full approach, rather than talking at the patient, it has to be, as we say, co-creation and working together as a partner. And that's pharmacists, patients, and also my other pharmacy colleagues as well. And this is why Asthma Right Care is there. It's very much around coming out with question and challenge cards and making this a little bit more fun, and so people are more receptive to learning.
Yeah, and I'm sure Alistair's itching to get in here, but I'd just like to first of all move to Erika. Are you with us, Erika? You were frozen last time. Yeah, that's it, lovely. Sorry, we couldn't connect with you last time.
Sorry, my internet keeps dropping in and out, so I apologise.
One tiny glitch so far. This is brilliant with so many people on the screen. Yeah, I just perhaps want to bring a perspective from Asthma UK on the discussion that we're just having about patients and thinking of things from a patient's perspective.
Yeah, I mean, I think I'll give probably the research and innovation perspective because that's what I'm most familiar with. I think we've made great strides in the last decade or so in really listening to patients, understanding their unmet needs, going as far as, co-creating research questions with them. I think we need to take this another step forward though, and to mirror what a lot of my colleagues are saying this evening. It's about this user-centered co-creation. It's not going to be just enough to understand needs and behaviours and take them away to our own room and work on by ourselves and come up with the solution and then present it back to people, because that's very unlikely to work. And I think we can make great learnings from the commercial sector here, where you look at commercial device development, particularly on straight kind of business to consumer models. So obviously I think we're all working with the assumption that everything we create is probably going to be paid for by the NHS and it's going to be distributed in that way. But if we try and learn from a business to consumer perspective, you really have to work with that consumer constantly. They have to be in the conversation continually, so that every single decision you make is one that they agree with. Otherwise, if we create a solution, even if it's based from the best data, we can't talk to every single person in the population before we start creating a solution. So we've got to continue to iterate that. And I think, user experience and user-centered design is what we need to do. And we need to learn from our commercial colleagues and ideally work with them, because those are the people who are going to be incentivized enough and have the knowledge and the experience of driving a product through to its completion, rather than the researchers amongst us who are great at generating evidence. We're wonderful at getting robust evidence, but we're getting evidence on a flawed model.
Yeah, and I think collectively what we have here are probably some of the solution, and it is looking at these things from different perspectives, and that's exactly what this evening is about. There's quite a few things coming through that are relating towards COVID and how suddenly many things have changed. One of my other roles is working with the NHS Digital Academy, and we've been looking at how much innovation has happened with COVID, and Hilary alluded to this, and I think we've had a conversation before, Hilary, also about your own GP practice in which you work, where you discussed video consultations for 10 years and then suddenly in 2 weeks it's done or something. So what is it? What was it behind that made people change? Hilary, I'll throw that at you, your practice and your own personal, what happened in your own practice.
It was context. That's why context is absolutely important. All of a sudden, you see, Catherine, you said we don't change, and most of the time you're absolutely right. We don't. We change very, very slowly. But there is another sort of change, which is almost, I was going to say catastrophic, but it is certainly overnight. The practice has become unrecognizable. I only go in 1 day a week now. 1 week I was seeing patients in the normal way, coming into my walk-in surgery and, typical GP surgery. The following week, I didn't see a single soul face-to-face. I was doing everything virtually. I was learning to use my iPhone for doing video calls. Literally in the course of a week, we changed. What changed? Context.
So I'm going to challenge that one back, and I might challenge Mike on this, who's spent some time trying to get systems to change. So when the context changes, do we all go back to ground zero?
I would say not completely. I've just spent 3 weeks doing nothing but telephone clinics, and in part they work very well, as Hilary's described, and that patients are grateful for the telephone distance and for the contact. But there are some things that you do need to do. Some patients you need to examine, some you need to make a measurement. A new patient, you can never really key in until you have the opportunity to see them face to face. So I'm pretty confident that we will offer patients in future the choice of a telephone consultation or a face-to-face one. And that disruption, I think, will be very positive. And particularly for people with asthma, because why would they spend a whole morning trogging up to a clinic when they've got a job to do? It's very difficult to contact people, but it's a lot easier to contact them through the telephone, and it only takes 5 minutes. So I found I can do 2 clinics in one, time-wise, from a telephone clinic, but I accept that there are limitations. but we'll have to work that out as time goes on.
And Dave, you alluded to context. So what's so different about Japan?
Fascinating, I think. I mean, it's one of the lucky things when I moved into the industry is the opportunity to work in different cultures and work a lot with Japan. And I think that what they've got, well, it's very difficult to generalize, isn't it? But what I see there and sense is that there is a charismatic leadership. There is a willingness to disrupt. I think what we're talking about with COVID is disruption. You know, something's happened to disrupt our world and it drives a change. In Japan, I think they've been willing to take on, for example, effectiveness evidence and grade it as high evidence and let it drive choices in their guidelines and implementation. So, you know, before I worked in Japan, I imagined the Japanese doctors and academics to be rigidly around internally valid science, but actually have a real openness. And some of the leaders there, Jun Tamaoki is one, have really been charismatic in their leadership around this. So the context is probably they had a big problem. They were very late to come into inhaled therapies, and they've made enormous change. So maybe they haven't become complacent yet as well. You know, maybe we were ahead of the curve and we've sort of become a bit, well, it doesn't matter anymore, near enough's good enough. I don't know, but it certainly is in a sort of phase of willing to be early adopters around disruptive change.
And Alistair, are there any psychological theories about the whole thing about fear and because obviously people have been afraid of what's happened. Has something else played into this that we haven't really thought about, or what happens at a time like this? Is that people, you know, how do they weigh up and making decisions and change? And is it a good time for us to really follow up with patients? And is it a good time for behavioural change?
Well, one of the things I was thinking about as I was listening to people come in on this point was one of the pivotal points of behaviour change is when the cost of staying the same outweighs the costs of changing. So context can be part of increasing that cost, but there can also be a cost in terms of threat to self. And the threat system activates and produces symptoms of anxiety or depression or other psychopathology. But the cost of staying the same can also be the kind of the impending threat to self. If I don't get myself into the best condition I can be in, how am I going to fare against COVID? Might be some of the things people are contemplating. So there'll be a huge rise in people taking all sorts of vitamins, exercising, eating much better, etc., etc. You know, people will have changed their healthcare behaviour with or without asthma. And I think that people with asthma, a lot of the early questions was, does this make me more vulnerable to COVID? And until those questions are answered properly, I think people will feel that cost of staying the same is being outweighed by the cost of change, if that makes.
Yeah, absolutely, absolutely, and that goes back to your, you know, the theory that Rob Horn has, isn't it?
Yeah.
And concerns. It's a similar kind of thought. People have got a balance and they're weighing up. Yeah,
that's it. And again, some of the things that have been coming up on the chat is how do we get some of the theories into practice around healthcare behaviour change. The best psychologist, clinical psychologist in the world can't enforce, cannot persuade people to change their behaviour. I think it's been receptive to hearing the difficulties that people have in changing that makes them speak aloud, say things aloud in front of people that they trust, and they almost begin to change themselves. We can't wave the wand and make them change. That doesn't exist. Motivational interviewing isn't a spell that you put on people that they walk out of the room and they change. It's been receptive and open to ambivalence about change, and we're all ambivalent about change, and our patients are no different.
I'd be very interested to hear from Darush the sort of things that people have been doing, you know, coming into pharmacy and buying or thinking about, or, you know, you've probably been the real, you know, you and your colleagues have been the real face of healthcare for many people over the last few weeks. Other people are available on the telephone. They've been coming in. Have you seen any changes, or have you heard from your colleagues about sort of things people are doing or buying or thinking they can, you know, vitamins have all gone off the shelf, I suggest, have they?
I mean, there's a lot of stockpiling of lots of things, and I think a lot of my role, because my wife, she's a nurse, she's working in intensive care, so I've been homeschooling, but I've been doing a lot of listening to my community pharmacy colleagues who've been saying, Darush, what's going on with all these inhalers? You know, what can we do where there's shortages, etc. So it's important to keep up to speed with that and give them the right advice. So I think at the moment with paracetamol, that's also, there's been quite a lot of shortages on that, which is understandable. And I think where the community pharmacies can really get involved is, you know, what to do if somebody's got high temperature at the moment with hay fever symptoms as well, where they could potentially get mixed with COVID if somebody's got a dry cough at the moment, or they're getting a smell, taste disturbances. They don't know whether it's to do with the COVID or the allergic rhinitis. So I think the Asthma UK resources have been really useful to share with colleagues around the tables of minor ailments and what could be COVID, what might not be. Yeah, so yeah, shelves are being cleared, but there's a lot of advice giving going on, which is good. They've kept the doors open. Obviously, PPE was an issue for a while, but keeping the barriers and the distances there. Lots of telephone support and also virtual support. And a lot of my pharmacists based in GP practices as well as doing a lot of medication reviews. And I think where there's maybe something positive, we're getting a lot of patients who with asthma who potentially haven't been taking their inhaled corticosteroids for a while, who now may be taking it a lot more seriously and getting, and we want them to be in the best possible lung health if they were to, God forbid, get COVID. So it's, and on my slide, I did have ICS as the inhaler to control symptoms, and that was something I borrowed off Professor Anna Murphy. So thank you very much for that.
And I suppose, Catherine, you know, when the doors unlock and everyone comes flooding back to the practice, what are you going to do with all these patients that's not had a review for all these months? I mean, it's a challenge that some people have been asking.
Yeah, panic.
Find your nurse, yeah?
Yeah. At my practice last year, we ran some group consultations for COPD patients, which were really, really successful. One examples I talk about is I was doing a little spiel about pulmonary rehab, and one of the patients said, "Oh, I've been. It was brilliant." I said, "Well, you do the presentation," and I had 10 patients there, and every single one of them signed up to pulmonary rehab because it was far more real for them to hear from somebody with their own condition than me going on about it. And so I've just done the training for virtual group consultations as well. So I think that could easily be a way forward, that you're actually seeing patients en masse. They're getting the education, they're learning from each other, and you're getting through the patients. It's beneficial not only for the practice, but also for the patients. And it's one option, I think. And patients are very, very receptive to it as well. I think I had one patient that walked out, but he came back to the next one. And I think maybe 1 or 2 patients that said no, they want to still see the nurse one-to-one, which was absolutely fine. But the majority said they're happy to be seen in a group.
It's very interesting, very interesting. So much we don't know. Have people just been, I go back to Darush and I think about Alistair here and David where you used it, and Erika. You know, people, initially it was a bit like the toilet roll story, that people, some of the pharma companies were saying actually, well, stocks are going down because people are either stockpiling or Darush doing what they should be doing. And we don't know. We don't really know until what's going to happen afterwards. So that's going to be a really interesting one. So I'm really conscious of the time. Time is getting quite tight now, and it's probably time to start to wind down this consultation this evening. There's a few funny things coming in. You know, people are very attentive and looking what's behind you and everything else. And, you know, I've learned a lot about watching Zoom. Zoom has come into all of our lives. But a few people are asking you, Darush, and talk about stockpiling. They're asking about where do you get your breathing tubes from that you've stockpiled behind? I think they're breathing tubes. Where have they come from? And are those inhalers you got on behind you? And are you the culprit?
So this is my garage converted to an office where I store a lot of my inhalers. And so I've got in-check dials at the back for inhaler technique coaching. And I've also got some lung tubes, which I managed to get from Stickler. They were very kind. If you go to the building blocks of a good asthma review on the PCRS Asthma Right Care section, you should be able to get an email from the person from Stickler if you wanted to order those. If you're still struggling,
nick them from you.
Yeah, I have a few supplies for my. I mean, there's only about 50 there, you know.
So is there one final comment, just one word from you all? We have an artist here who thankfully Claire has tried to capture everything tonight. This has been filmed on YouTube and will be available. I just wonder if there's one word that would sum up your presentation this evening or what you've heard tonight, one word only, like one slide. What would that be? Who would like to go first? Someone can raise a hand. I'm not. Okay, I will. Oh, great, Erika. One word.
I guess my word would be collaborate.
Collaborate. Fantastic. Go up to Alistair. Yeah, Alistair, you're in a very beige room. There you are. Yeah, great.
My word would be listen.
Listen. Have we heard that? Fantastic. David?
I think I'd say simplify. Simplify.
Fantastic. Catherine?
Change.
Change. Mike?
I had optimistic realism. I know that hyphenated, of course.
You can hyphenate it. Fantastic. Hilary?
I think I'll go for behaviour change, which is also hyphenated.
Okay. Darush?
One word.
At all levels. Clinicians, healthcare professionals, right down to the managers, patients, politicians, everybody. Some behaviour change and understanding of it.
And perhaps training in behavioural change.
Indeed, all the training and everything that goes with it.
Alistair has introduced us to tonight. Darush, you can have the final word.
It has to be pharmacy.
Can I just thank my speakers very much indeed for a fantastic evening. I very much have enjoyed it. I also want to thank Claire for capturing the evening. We will be publishing this subsequently, so you will get a chance to see it. The recording of this webinar will be available. And for further information about Right Care, I'm sure our speakers have certainly our PCRS Right Care speakers have really encouraged you to go and find out about all those other resources. And if you want more information about research and the work of Asthma UK Centre for Applied Research and the real life research that we actually do, which is about applied research, then please go to our website. So once again, thank you all very much indeed. I'm so sorry we couldn't get round to all of your questions, and have a good evening. Thank you. Bye-bye, everyone.
Bye.
Bye.